We are live now. With all your permission, I am starting this session.
Sure.
A very good evening to everyone present here. I am Faraz from IGCP Group. I welcome all the participant doctors on today's session. Let's welcome today's speaker with great honor, none other than Dr. Keshav Murthy CB sir. Sir has done MBBS, MD in General Medicine, DM in Cardiology, DNB in Cardiology, and he is consultant at Manipal Hospital, Mysore. Today, sir is going to discuss on a topic, how to read ECG. Let me tell you overview of the topic. An electrocardiogram, that is ECG, is a fundamental in accessing cardiac health. An ECG is a graphical representation of the heart's electrical activity. One must understand the essential components such as P, QRS, and T waves corresponding to different cardiac cycle phase and interrupt it. Additionally, analyzing the arrhythmic rate and intervals provides valuable information about the heart functioning and potential abnormalities. For more this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Yeah. Thank you, Mr. Faraz, for the kind introduction. And a warm welcome to all the participants of this session on a normal ECG. The basic idea of taking an ECG and seeing an ECG and understanding it is to diagnose heart-related problems, especially if there are acute events like myocardial infarction or ischemia or unstable angina. We should be able to make out whether there are changes on the ECG and whether any urgent treatment is required, because in cardiology, as you all know, time-dependent treatment saves a lot of lives. With that intention, we'll start this class today and see a very basic class it is today with some examples of normal ECGs and how to go about reading and what are the points to remember when we see ECG for the first time during our medical course or after MBBS or even while doing a post-graduation. We all get scared that we cannot make out anything or we may miss something important on the ECG. It all looks very strange at that time. But if you go methodically, step by step, and try to understand how to read an ECG and remember all the points that I say today, you should be able to give a basic interpretation of ECG and not miss many of the things. So in this class, we'll learn about how to perform an ECG correctly, which is very important because different people take ECGs, the technicians, the nurses, and sometimes the people who are not been trained to take an ECG also take an ECG. So we should be careful and probably supervise the first time an ECG is taken in your center. We should also learn to describe an ECG methodically, understand the main features, identify a basic normal ECG, and distinguish between various arrhythmias on the ECG, and basically be able to tell whether a patient to whom the ECG belongs requires emergent treatment or he can wait for a cardiology consultation. And a basic triage has to be done for each and every patient to whom from whom an ECG is taken. So this is about electrode placement in the 12-lead ECG, which is an extremely important thing. We all know about the Einthoven's triangle, which is a triangle between the right arm and the left arm and the left leg, which is the electrical basis of how an ECG is derived. An ECG is nothing but an electrical signal of the heartbeat. We know that heart is an organ which requires electromechanical coupling. That means the heartbeat is initiated electrically and then sustained by a mechanical beat, and that mechanical beat is what produces the cardiac output, and that's how a person is alive. So in the Einthoven's triangle, there are three main points which are important: the right arm, the left arm, and the left leg point. Right leg point is, of course, the limb lead, which is a kind of a dummy lead or a neutral lead. The placement of the leads have to be proper to get a proper ECG. Suppose we do not place the leads properly, we can misread the ECG, we can not calculate the voltages properly, which may lead to a wrong result sometimes. And you have to be extremely careful. You can read it up on the internet or see YouTube videos, but learn and perfect the technique of placing the chest leads properly. We have seen some of even the senior technicians and nurses who have done thousands of ECGs, they place the chest leads improperly. And sometimes when you are standing on the left side of the patient, Commonly, the limb leads are misplaced or limb leads are interchanged. So these sort of things can lead to various confusions. Therefore, methodically, the leads have to be placed at the correct points for proper ECG taking and interpretation. So here it is given where V1, V2, V3, V4 are placed, V5 and V6. There are additional leads, of course, which we can place V7 to V12 on the back, and the right-sided leads in a similar fashion like on the left side, we place them on the right side to take ECGs of patients with dextrocardia. And in patients who have right ventricular myocardial infarction, where we need to see the signals from the right ventricle, we take a V4R, V3R, V5R, and additional leads can be taken. So this is how the chest lead placement occurs. In a standard ECG machine, all these are color coded and they are kept in the, they are labeled independently so that there should not be much confusion. The only thing is where we place the lead on the patient and how we put the gel. Suppose we put the ECG electrode gel as a smudge across all the leads will be connected, then the voltage reading may not be appropriate. So red stands for right, yellow stands for left arm, and green stands for the left leg. So that is how you place the leads properly. It is color coded. Internationally, the same coding is used so that across the world, it should be the same coding. This is what we call as axis, which confuses many of the people. Even advanced ECG readers sometimes get confused about the axis. So don't worry too much about it as beginners. As you go on reading ECGs, you will recognize what is normal, what is abnormal axis, right and left axis. That should be enough for basic ECG interpretation. So normally the axis is between 0 and 90, and some extension is given towards -30 and +120. But beyond that, the electrical axis of the heart is abnormal, depending on which ventricle is dominant, hypertrophy patterns, or hemi-blocks in circulation, hemi-blocks in the conduction system, the axis changes. So limb leads look at the heart in the coronal plane. 1, 2, and AVL, they are called as lateral leads, and also V5, V6, which are the high lateral leads. 2, 3, and AVF are called as the inferior leads because they pick up electrical activity from the inferior surface of the heart. AVR is the right side of the heart. It gives the AVR is an augmented right-sided lead. So this is how a normal ECG looks. Of course, the label has been removed for removing identification. You see that there is a P wave, there is a QRS complex, then there is an ST segment and a T wave. All the complexes appear fairly similar to each other. They are regular at isoelectric intervals. That means they are at equidistant from each other. And also the baseline, which is the TP segment, it seems to be in the same plane. It should not be hovering too much. So when you see something like this, which is quite symmetric and the rate is QRS complex is quite regular, the P and the QRS are in constant relationship. There is no change in that. There is not much change in PR interval. Then you can call it as a fairly straightforward as a normal ECG. Just showed it as a normal phenomenon just to record it in your mind. So this is how a normal ECG looks. I'll tell you what are the points to be seen in a normal ECG. So next we look at the chest leads, where V1 to V6 look at the heart on the transverse plane, that is in a plane which is perpendicular to the coronal plane. V1 and V2 look at the anterior part of the heart and the right ventricle. V3 and V4 are called as the anterior and septal leads, and V5 and V6 are called as the lateral leads. These are the common nomenclature. So when you say anteroseptal MI, ST elevation is seen in V3 and V4 predominantly, but also in V2 and V5 and V6. In lateral or high lateral myocardial infarctions, ST elevations may be seen only in V5, V6, and 1 and AVL, which are the left-sided leads. So this is again a normal ECG, just to give an idea of how a normal ECG looks. So what are the elements and what are the things we are talking of? What are the waves and how they are named? So that we have to know in a basic ECG. So the first positive deflection after the isoelectric line as the P wave. The interval from the onset of P to the first negative deflection, which is the Q wave, that is called as a PR interval. So always remember that an interval contains a wave and a segment, whereas a segment contains only a straight line. It doesn't contain a wave. So this is called a PR segment. PR segment is the between the end of the P wave to the onset of the first negative deflection. So in the ECG, the first positive wave is the P wave. The first negative deflection which you see is called as the Q wave, which may be pathological or normal. We'll describe that in the later ECGs. Then the next positive deflection is the R wave, which is the tallest wave on the ECG. And it depends on where you place the leads and which is the dominant ventricle in the particular patient. Then the next negative wave after the R wave is the S wave. And then the ECG returns to the isoelectric line. And then you see the ST segment. The most important part to diagnose ischemia and myocardial infarction is the ST segment and the T wave. So the QRS complex, this is the initiation of electrical activity, the conduction through the AV node. Then this is the activation of the ventricle or the depolarization. And from the S wave, the ST segment and the T wave indicate the repolarization area. So most of the abnormalities of ischemia and myocardial infarction occur in this region, and we have to be careful with examination of this region and learn how to interpret it properly. So this is how a normal ECG complex looks, normal QRS complex it is called. So here you see a correlation between what I was talking now. P wave indicates atrial depolarization. The QRS complex indicates ventricular depolarization. Then the ST segment and the T wave ventricular repolarization is what is indicated there. So that is how it is correlated on the surface ECG. So while interpreting the ECG, what are the things we have to check? As soon as we see an ECG, several mistakes occur if you do not label the ECG. So I recommend that even as the ECG is being taken out, getting printed out of the machine, the first thing you should do before even reading or trying to see urgently what is there is to stick the patient's name and other details, identification of the ECG. Many mistakes have occurred due to wrong identification or mislabeling or wrong patient's ECG being read, which is extremely disastrous in the modern era. So as soon as the printout comes from the ECG, even before you tear out that paper, stick a label with the patient's name or hospital number and age or whatever details you want to put on that. This is very important for putting all these details on the surface ECG. Now, many of the modern machines ask for these details to be entered before taking an ECG, but in an emergency, you tend to kind of override because you don't have time to put name, age, sex, date of birth, everything, and you take an ECG, but don't forget to put the patient's name label, ID. If you are doing an elective ECG, then it is mandatory to enter all these details so that it comes as a printout. Then there won't be much confusion. You have to check on the calibration. Most of the modern machines, like I said, they are auto-calibrated to take an ECG, and if there is a change in calibration, they do warn you and then don't change the calibration on their own. Then observe the rate, rhythm, axis very carefully before giving a final interpretation about what is this particular ECG showing. Check that the ECG is calibrated correctly. What do you mean by calibration? 10 millimeter height is the correct calibration because that indicates 1 millivolt of energy. So if you see the 10 squares, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So this is the correct calibration. It should be properly rectangular. It should not be cross. This limb should not be cross or dark or thick. It should be a smooth, normal, rectangular shape of calibration. Then you can say it is correct. Otherwise, you have to go back and adjust the machine. This we were doing in the older machines where you had to look at calibration, but most of the newer ECG machines are auto-calibrated. And paper speed is set at 25 millimeters per second. Sometimes by inadvertently, if you take at 50, the complexes will look far apart, or you take at 12.5, they look close together. So you may misinterpret the heart rate. So take care that the standard ECG speed is 25 millimeters per second. and the standard calibration is 10 millimeters for every millivolt. So this is how the ECG looks these days. There is an auto interpretation which comes on the left side of the screen. Many of the newer ECG machines have a software which automatically interprets the ECG and gives most of the measurements. Many times it is correct. Almost 90% of the times, the intervals measured, the rate measured, the axis, the corrected QTC, everything comes automatically. Earlier, we used to calculate most of the things manually. Only thing you have to see is sometimes if there is an artifact or some gross change on the surface ECG, the machine may interpret as myocardial infarction or artifact or something which you have to carefully check it and then make an interpretation and then sign off the ECG. Then it becomes authenticated. So what do you need to look for? As soon as you take out an ECG, you see that the standardization is correct. The paper speed is correct. Are the limb leads set up correctly? As I said, if the limb leads have been interchanged, it can lead to a false diagnosis. It can lead to abnormal Q waves appearing on the ECG. And if the chest leads are not set up correctly, you may end up misinterpreting the voltages. And is the ECG free of artifacts? It may be movement artifact or muscle tremors or whatever. Due to extreme cold, there could be some artifacts. So all this should not be seen on a properly taken ECG. So these are some clues that the ECG setup has occurred properly or not. AVR, which is placed augmented right lead, is always negative, except in cases of dextrocardia, it can become positive. Lead 1 is always positive in most of the instances. Chest leads show smooth R wave progression and the R to S transition, that is, R wave becomes dominant usually in V3 or V4. And the R wave being very small in V1, it progressively becomes small to tall from V1 to V6. So if you see all these 4 points are correct, then you can say that it may be a reasonably properly taken ECG. If any of these are abnormal, say AVR is fully positive or lead 1 is negative, which may occur in gross right axis deviation, R wave progression is reverse or something has happened to the R wave, it is not progressing properly, and the lead is not, the R wave progression from V1 to V6 is not small to tall, then you have to suspect other things, either a grossly pathological condition or that the ECG has not been taken properly. So see here that the leads have shown that in lead 1 it is negative, in AVR it is positive. So most likely this patient has had a limb lead reversal, which you may wrongly interpret it as a myocardial infarction. You will read this as a QS and a T wave inversion, which may lead to a wrong diagnosis. So you have to set up the leads properly and read it properly to get a correct diagnosis. So the other problems, of course, artifacts, electrical interference, muscle tremor, and wandering baseline, these are all common problems. Most of the things have been sorted out with the newer machines. Wandering baselines are made perfect by post-analysis or post-processing. If there is continuous muscle tremor, as in Parkinsonism, that cannot be controlled because it is a patient factor, or patient is having some seizures, or uncooperative patient, children where there is constant movement, you can get a lot of artifacts. If there is an electrical interference, you remove the plug from the mains and run it on the battery. That removes most of the electrical interference. If patient is wearing some metallic objects or something is grounding that or causing an electrical disturbance, you can remove those objects and transiently put off the other monitors and things like that, which may cause electrical interference, mobile phones and things like that. So that will give a proper ECG. Artifacts, of course, I'll tell you how to read the artifacts and separate them. See, if you see a normal looking ECG, but only in one place you are seeing something grossly abnormal. This looks like a wide QRS, which is occurring between two normal QRS. And that too only in lead 1 and lead 3. It is not consistent. So when you see something very inconsistent like that, it is likely to be very likely to be an artifact. If you see gross movements of the baseline, then you have to suspect that it is tremors to the patient or a Parkinsonian patient. It should not be interpreted as atrial fibrillation. Sometimes people have called it as ventricular fibrillation. You do not see it properly and interpret properly, patients may receive wrong DC version. Sometimes patients are shocked unnecessarily if the leads are not properly placed and a ECG is taken or ECG is repeated. If in doubt, always set up the leads properly again, look at all the ECGs carefully and take another ECG. It just takes about 5 minutes, but you will get a good and proper diagnosis. So if there is muscle tremor due to any cause, you will get fine fluctuation. It is not consistent with any particular arrhythmia, so it is due to muscle tremors or movements of the patient. So this is again a similar one. You see it only in lead 1, lead 2, and a rhythm strip. It is not seen in the other leads, so it is likely to be a artifact. So the artifacts are quite easy to recognize. So the basic observations, we start with the heart rate, rhythm, whether it is regular, whether the rhythm is arising from the sinus or not arising from the sinus, which makes a big difference for us in treatment. And the intervals, the PR interval, QRS, ST segment, all these are looking normal or abnormal. So you should go systematically with the rate, rhythm, axis, intervals, QRS complex, ST segments. So if the heart rate is regular, we can count the rate by counting the number of large squares between the R waves. Suppose the number of large squares, that is RR interval in large squares. The rate is equal to 300 divided by RR. So if you see basically the heart rate is around 100, you will see that there are the 3 QRS complexes between the 3 large squares between the QRS complexes. So RR is equal to 4 large squares. 300 by 4 will be 75. 300 by 3 will be 100. 300 by 2 will be 150 heart rate, like that. So this is the simplest way of calculating the heart rate from the ECG when the heart rate is regular. You can also use the box method. This is what was shown in the previous slide. So if the heart rate is irregular, then what you do is you take a rhythm strip, count the RR QRS complexes in a 2 second or a 3 second strip, and then multiply it by the appropriate seconds to get the heart rate per minute. So that is in atrial fibrillation and conditions. In sinus rhythm, you can get 300 divided by the number of large boxes. So rhythm, in sinus rhythm, cardiac impulse originates from the sinus node. Every QRS must be preceded by a P wave. So P and the QRS are married to each other, so they continuously and consistently come with the same morphology. The P wave and QRS should come at the same interval. They should have the same morphology to be for us to say that they are related to each other. So what do we mean by that? This is a P wave, this is a QRS. This is a P wave, this is a QRS. P wave and a QRS. They are coming at the same interval. They are looking similar. Then you call it as a sinus strip. Here, of course, in this strip, you are having some ectopics, which are quite a wide QRS, and T is inverted. This QRS doesn't look like this, and it has not come at a time where it has to come. So it has come earlier. So it is called as a ventricular premature complex because the QRS is wide, looking much different from the normal QRS. So the PR interval is measured between the start of the P wave to the start of the QRS complex. Therefore, if there is a Q wave before the R wave, and PR interval is measured from the start of the P wave to the start of the Q wave, not the start of the R wave. So how we measure it is beginning of the end of the PR interval is measured from the start of the P wave to the start of the first negative deflection. So that is the PR. So are there any pathological Q waves is the next thing. So how do we define a pathological Q wave? Q wave may be pathological if it is deeper than 2 small squares or 3 small squares or more, and wider than 1 small square. That means 0.04 seconds. Each small square is 0.1 millimeter in height and 0.04 second in width. That you have to remember. So a pathological Q wave is one which is deeper than 2 small squares and wider than 1 small square. You may have physiological Q waves, which may be present in the lateral leads, ventricular hypertrophy. So these are all called as physiological Q waves, which are narrow and the depth is not more than 2 squares. Whereas pathological ones they are deep and they are wider than 1 square. So that is how we distinguish between pathological Q waves. Pathological Q waves indicate old myocardial infarction. Physiological Q waves may be present due to various physiological ones. So the QRS height is the next thing. If the complexes in the chest lead look very tall, consider left ventricular hypertrophy. If the R waves are very tall in V5, and the tallest R wave we usually see is in V5. If it has that criteria we'll discuss later, ventricular hypertrophy criteria, then you should consider a diagnosis of left ventricular hypertrophy. The depth of the S wave in V1 added to the height of the R wave in V6 comes to more than 35 millimeter. When you add up those things, then left ventricular hypertrophy is present. Normally, the width of the QRS complex should be less than 3 small squares. It should be 0.12 seconds or less, even 0.10 seconds, 2.5 small squares. If the QRS is wider than this, it suggests that there is a ventricular conduction problem. The narrower the QRS is, it is the better. So you may have left middle branch block where the conduction system has a problem, so the QRS is wide, or you can have a right middle branch block. Either of these middle branch blocks can cause widening of the QRS complex in respective leads. So for QRS width, it is important to look at leads V1 and V6, LBBB and right middle branch block. You can use that mnemonic to see what is the pattern in the leads. And it is usually either caused by infarction or fibrosis. Sometimes it may be physiological. Otherwise, structurally, heart is normal, but they can have middle branch blocks. So what are all the various elements that we discussed till now? P wave, magnitude and shape. Like in P pulmonale, it can be sharp and pointed. And in P mitral where left atrial enlargement is there, you can have a bifid P wave. And the second part of the P wave, the later half of the P wave, looks like an M, with the second portion being higher than the first portion of the M. So that is a P mitral. Then the PR interval, start of the P to start of QRS, normally 3 to 5 small squares, 0.12 to 0.20 seconds. If it is more than this, more than 0.20 seconds, it's called as a first degree heart block, indicating conduction of the impulse from the SA node to the AV node. ST segment should always be isoelectric. That means it should be in line with the TP segment. And whenever it is upsloping and the point from where it takes off from the QRS complex, which is called as the J point, if it is elevated, that can be pathological. You have to distinguish it from isolated J point elevation, which can occur in early repolarization to ischemia and myocardial infarction. T wave magnitude and direction. Normally, the T waves are upright in almost all the leads except in AVR and in V1, where you can find T wave inversions. Sometimes physiological T wave inversions can occur in lead 3 along with a Q wave. And when you take it in deep inspiration, that may disappear, which is only due to the position, more horizontal position of the heart in some pictures. The QT interval normally 0.10. Less than 2 big squares or 0.4 seconds at 60. This is usually rate dependent. That's why we have what is called as a rate corrected QT interval or QTC, which is simply the normal QT interval divided by square root of the RR interval. Then you correct it to the appropriate rate. So this is what we have seen: rhythm, sinus or not sinus, morphology. Where is the beat arising from? Supraventricular means the QRS is narrow, less than 0.12 seconds. And in ventricular, the QRS complex is wide and it is not preceded by a P wave. That's how to distinguish supraventricular from ventricular rhythms. So here again, we look at a normal ECG after looking at all the factors. I'll just describe it for you. This is the P wave and the PR interval. There is no abnormal Q wave here. The tiny Q wave is seen here, which may be passed off as physiological. The QRS complex appears narrow and quite normal. The ST segment is isoelectric. That means it is in line with the TP segment. The T wave is upright. As I said, the T wave is upright in almost all the leads except in AVR where you see a inverted lead, and in V1 where you see a inverted lead. Sometimes AVL in a vertical heart you can have that kind of a complex, but otherwise ECG looks very symmetrical and normal. If you see in the rhythm strip, the complexes are all coming very regularly. And P wave after a certain time interval of say 0.12 seconds, it is followed by a normal looking QRS, normal looking ST segment, and a normal looking T wave, which is not inverted, it's upright. So when you see things like this, clearly things are normal. Okay, and the axis is also normal. So normal ECG, sinus rhythm, rate 50 to 100, axis minus 30 to plus 90. Intervals, PR interval, as we discussed, 0.12 to 0.20, QRS less than 0.12 seconds. So in summary, what all the things, you remember here, the fingers, all the 10 fingers. So whenever you look at ECG, after you finish the identification, identifying the patient, and take the ECG for interpretation, you start off like this. So if you go through like that systematically, you will not miss out on anything and you will be able to give a proper diagnosis. Identification, standardization, whether leads are placed properly, rate, rhythm, axis, which we discussed, P wave and PR interval, QRS morphology, ST segment and T wave changes. If you see anything unusual, some unusual waves, and we are able to distinguish whether they are artifacts, that will help you to interpret the ECG problem. Finally, one word of caution, always interpret the ECG along with the patient. When you see only the ECG, you are likely to make mistakes. If you see the patient, ask his history, get a grasp of why a ECG has been taken, whether the patient has palpitations, chest pain, whether he has presented to the emergency room with an acute myocardial infarction. If you see the clinical setting, then diagnosis will be easier, and always try to correlate between the patient's symptoms and the ECG. Many times it may not be possible. You may be told to interpret an ECG which you get on the phone or you get on the mail. Then you have to be perfectly go according to these points, and wherever possible, try to get a history and then give you a proper diagnosis. Only relying on an electrical signal without looking at the patient, without looking at the physiology, without looking at what mechanical problem patient has may lead to misdiagnosis or wrong diagnosis, which may finally lead to a wrong treatment. So always be careful. Follow all these 10 points and remember these 10 points like your 10 fingers of the hands. Then you will never miss out on anything and you will be able to easily make a diagnosis. In the next two classes, we'll learn a few things further about how to interpret the various changes, abnormalities, maybe some rhythm abnormalities also will be shown to you, and one or two specific conditions like aortic stenosis or hypertrophy patterns we'll try to see in detail. So ECG is not just about the theory of going through classes and hearing it. ECG is learned by seeing ECG. So if you can see serially 1,000 ECGs, you will master the art of reading ECGs. So as soon as there is an ECG, show some curiosity, show some interest, it may be normal. Just pick up the ECG and read it according to these 10 points. Initially, you may not be able to tell everything about it, but make an attempt, make a serious attempt and write down behind the ECG itself or in a note what you have found and then discuss with somebody. That is how you learn ECG. That's how the journey of learning an ECG happens. So thank you all for your patient hearing, and I hope it was a useful class in terms of knowing something about some simple things about a normal ECG. Thank you.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one, sir. I definitely think this session knowledge is going to help all the participant doctors who have joined this session. Sir, I can see, sir, we have received some question from the participant doctors. If you allow, can I take this question with all your permission?
Sure, you can.
Yeah, Dr. Subramaniam is asking, what is the role of ECG in the diagnosis of anomalous left coronary artery from the pulmonary artery ALCAPA?
Yeah, in Al-Kappa, it may show myocardial infarction patterns because of ischemia and increased flow, and because it is a deoxygenated blood which is coming into the left system. So you can see changes like a myocardial infarction. So if you see myocardial infarction or abnormal or pathological Q waves in infants or small children, you should suspect Al-Kappa.
Thank you so much, sir, for answering. I hope that Dr. Subramaniam has received his answer. Moving forward, there is another question, sir, from Dr. Subhangi. She's asking, a patient with coronary artery disease and hypertension present with an irregular pulse. What does the ECG reveals?
Most likely these patients would have atrial fibrillation, because atrial fibrillation is the commonest sustained narrow QRS arrhythmia in human beings. So in this setting of ischemic heart disease and hypertension, atrial fibrillation is quite common. So it would be very likely to be atrial fibrillation.
Okay, thank you so much, sir. We will be taking one last question from the doctor. Shubham, he is asking, which ECG finding indicate an infradonal second degree anteventricle AV block? Which ECG finding helps determine its correct side and off block?
Right. This we'll discuss in the next class when I talk of ready arrhythmias.
Okay, sir. Thank you so much, sir. And one feedback from Dr. Subramaniam. He has written, wonderful session. Thank you so much for your precious time.
Right. Thank you for your time too.
Okay, thank you so much, sir. I hope that all the delegates have joined and understand about this topic, sir. One of the most important topic in the field of cardiology. Like once the access is done properly, then the treatment is also done, right, sir? So
Right.
thank you so much, sir, for once again for giving your valuable time and sharing your knowledge, sir. As there is no more questions, sir, with all your permission, shall we conclude this session?
Definitely. Thank you for
Okay,
the
thank you so much, sir. Yeah, great, sir. Great to have you, and we will till then take care of yourself, sir. Hope to see you again with different topics, sir. Have a great day, sir.